లాస్ట్‌లో రామప్రసాద్ సార్ ఏమైనా క్వెషన్‌లు అడిగినా ఓవర్ టు చైతన్య నిన్న రాణి మేడం అన్నట్టుగా యంగ్ అండ్ డైనమిక్ కన్సల్టెంట్.
మరి ఇందులో ఉన్నట్లేదు.
ఉంది సార్, ఉంది, జాయిన్ అయింది సార్. సార్ మా ఐసీయూ అరాచకంగా ఉంది సార్. ఏమనగానే పరిగెట్టాలి. 5 6 కేజెస్, అందులో 5 వెంటిలేటర్ మీద ఉన్నాయి. ఓంకార్ని అక్కడ పెట్టొచ్చా.
ఒకసారి గ్రూపుల్లో మళ్ళీ ఒకసారి పెట్టు. మన కిరణ్ కి
పెట్టాను సార్, స్టార్టింగ్ ఇన్ 2 minutes అని పెట్టాను. 1 minute ఆగి స్టార్ట్ చేసేద్దాం. ఫుల్ స్క్రీన్ విజిబుల్ ఉందా?
Visible.
Lights moving. Okay. Good morning, madam. Another madam.
Good morning, Shrikant.
Okay, we'll start slowly. People will join. Good morning, everyone. So the topic we all know about this one, starting from pathology of our MBBS third year. So we will be on the journey to anesthesia in this class. So the topic will briefly cover the inflammatory response, how it happens in the perioperative period and how it goes, and briefly few strategies or techniques or drugs we can implement to reduce the inflammatory response syndrome perioperatively. So we all know the thing that differentiates higher races from the lower animals is one of the evolutionary hallmark of human beings is the immune system. So the immune systems defend the host against the invading pathogens and also exogenous infections. And the same way, even when an injury occurs or a tissue trauma occurs, the immune system behaves in the same way and prevents our body and protects against the tissue damage. But as we all know, all these things has to be in perfect balance when they happen. So if there is a overshoot of the inflammatory response, there will be more organ damage than protection. So which is what we will be going through in this topic. So the immune system, which can be conceptualized as a functional organ system, protects the human body against pathogen invasion and externally caused homeostatic disturbances. Appropriately scaled inflammatory response aid the organism in combating infections, whereas excessive immune reactions may cause organ damage, including acute respiratory failure and kidney injury. So an ideal balanced level of inflammation thus requires a locally restricted, precisely timed immune response. So what happens when there is a tissue injury that leads to the release of damage-associated molecular patterns, which are nothing but a polyformyl peptides with containing DNA, which in case of DAMPs, it's mitochondrial DNA. In case of PAMPs, which are released in response to infection, they contain the bacterial DNA. These are also called as alarmins because they alarm the human body against something bad is going to happen. You have to fight it out. So the alarmins, then what they do, they're actually intracellular, but when some response or some external injury occurs, these come out of the cells and are secreted into the extracellular space. So the alarmins bind to evolutionary conserved families of receptors, including toll-like receptors, expressed on a variety of endothelial, somatic, and hemopoietic cell lineages, and subsequently they will activate these cells. So what happens next? So something danger has come, DAMPs have been activated. They have acted through these receptors and all, and start to activate the expression of molecules. Leukocyte, they facilitate the leukocyte migration and other adhesion molecules, and the release of inflammatory mediators will occur, and eventually the recruitment of immune cells. So all this is good enough. So there will be cell secretion, migration, and inflammatory mediators and all. So the problem comes when there is an lack of balance in this response. An unbalanced and unrestricted perioperative inflammatory response may thus produce a systemic inflammatory response involving endothelial cell activation, glycocalyx damage, inflammatory mediator release, and immune cell activation. So this is the homeostasis we are talking about in the past few slides. If you can see on the left one, so that is in response to a pathogen or an infection. We all know a severe sepsis can cause a full-scale immune activation. That's the latest definition of sepsis also covers. If you see on the y-axis, that is the degree of the immune response. So that is a full immune defense activation occurs in response to pathogen, followed by resolution following pathogen clearance. So if you see the right one, the graph, that is not so high in peak of immune activity compared to the pathogen. This is due to some local trauma or a surgery. It should actually and ideally should be locally restricted inflammatory reaction, and the resolution should be good enough. So that's what immune homeostasis should do. But why in some cases we see the disproportionate immune reaction is, unfortunately, the body cannot differentiate between, in some cases, it cannot differentiate between the immune response elicited by an infection and a surgical or other trauma to the tissue. This is established by the fact that so many times we have the DAMPs, which are released, peptides released due to some tissue damage like surgery or an injury, an external injury, and also the PAMPs, that is pathogen-associated molecular pattern. They're so similar in structure. Both are peptides, only they differ in the mitochondrial DNA for DAMPs and bacterial DNA for the PAMPs. They act through the same receptors. They produce the same sort of effort. So the body sometimes fails to distinguish the amount of immune response it has to mount in response to some degree of damage to the skin or any other tissues. So this is how an imbalance of response occurs, and there is lot of research going on, and we are still in the research phase for most of them, where in future we may see or identify the stage of immune response that is going on, and we can go for a targeted therapy based on the timing and of the immune response and how severe it is. So tissue damage. Surgery involves breaking of skin and damage to tissue or organ barriers that triggers the release of inflammatory mediators. Even minimally invasive surgical procedures aiming at limiting tissue damage cannot completely abolish the mediator release. The data from murine systems suggests that normally macrophages reside in skin tissue, but also that neutrophil influx occurs from skin incision over 24 hours, followed by a sharp decrease over the next 8 days. So this is briefly a diagram depicting the injury to various levels of our body: skin, fat, organ, and microcirculation. And accordingly, the inflammatory mediators or chemokines and interleukins are released. Which organ you are going to damage, how depth it is. So it all depends on the extent of injury to the our body and also the duration of the injury.
Ashok,
In addition to
case
skin,
better.
so in addition to skin, the incest subcutaneous fat also
mic off
plays a
cheyra.
major role.
Shrikant, mic off అన్ని చేయండి.
Sir.
You off the other's mic.
No, sir. Just I'll choose an only. Okay. In addition to skin, the incised subcutaneous fat also plays a major role with regard to inflammation post-surgical infections. So in a 2018 study of patients who underwent surgery for Crohn's disease, the thickness of the subcutaneous fat layer correlated with surgical site infection, because adipocytes are not only sensitive to TNF-alpha, but they are themselves capable of secreting TNF-alpha. So with regard to tissue penetration and cutting, bleeding also itself may trigger an immune reaction, which is why we have to, if possible, limit the bleeding in any surgery to decrease the immune response. So we'll be spending next couple of minutes on this slide. This is basically the crux of the entire class of inflammatory response syndrome. So this depicts two halves. As you can see, the upper half is the inflammatory response and lower half is the resolution. When there is an imbalance between these two halves, which will cause an exaggerated immune response and cause trouble to the patient and also the treating physician. So what happens if in the immune response part? So the DMPs are released. You can see here the DMPs will cause DMP chemokine activation, and then comes the platelets, and they will interact with the leukocytes. The leukocytes are released. They will interact with other cells which are also activated due to immune response, and all these changes occur. Coming to cytokines, which are termed major in the inflammatory response syndrome, there will be cytokine homeostasis dysregulations. So as we all know, cytokines are a diverse family of peptides released by macrophages, natural killer cells, and T cells. And surgical procedures will eventually lead to release of multiple cytokines, which will generally peak immediately after surgery and correlate with the duration and extent of the surgery. So more damage that occurs to tissues during the surgery and also the duration of surgery, both will cause the increased number of cytokines released into the system. And also these cytokines, there will again activate the other cells, recruit more and more leukocytes into the damaged area and all. So also when we talk about cytokine release, another important factor which we will also be seeing in the future slides is the tidal volume in the mechanical ventilation we are providing in general anesthesia cases. So it is there are multiple studies and evidence that usage of higher tidal volume 10 to 12 ml per kg body weight versus lower 5 to 7 ml per kg body weight tidal volumes lead to release of TNF alpha and IL-8 even in patients without systemic inflammation. So the high tidal volume is generally dangerous when we are talking about the immune response. So then comes the endothelial cell activation and dysfunction. So what happens is pro-inflammatory cytokines lead to endothelial cells, two types of activation in the endothelial cells. So there is a type 1 which triggers the neutrophil and platelet recruitment. This you can see it here, platelet leukocyte interaction. And the second type, what we see, which will initiate the expression of the inflammatory cytokines and other adhesion molecules. So what happens is platelet leukocyte interaction also causes this endothelial gapping, increase in the leakage of the protection barrier. And also the leukocytes, what they do, they will recruit and they will migrate through this, and they will sort of attach to the cells and roll on them. And in the process, they will recruit more and more cells into the area of damage. Again, the pre-selectins and deselectins, they will help in this process of neutrophil migration and the recruitment. So also this endothelium glycocalyx damage also plays a major role in the immune response. So this is a protective sugar-like coating of endothelium glycocalyx. So the glycocalyx degradation products are both pro-inflammatory and anti-inflammatory too. And this will eventually lead to endothelial swelling and also the increased leakage through that and the subsequent edema, what we see in the inflammation and all. So then after a period of time, eventually it has to come down, the inflammation has to come down, where we will see the lower part of resolution of the inflammation. So when it comes to resolution of inflammation, again, some of these cells which are actually causing the inflammation, whatever it may be, macrophage and all, they will actually aid in the resolution of the inflammation too. So the pro-resolving molecule mediators like marcesins, resolvins, and protectins, these are actually released by macrophages only. And then the pro-inflammatory will develop into the anti-inflammatory cell types from the macrophages, and this will cause these changes, edema, resorption, neutrophil apoptosis and clearance, which is termed as efferocytosis, where the apoptotic cells are effectively cleared by the macrophages, and endothelial cell restoration occurs, and the restoration of tissue integrity, including the glycocalyx, which is damaged, occurs, and the body returns back to the normal state. So enough of the pathology, then we will move to the what are the risk factors or perioperative factors which will cause an amounting of response. So type of surgery, open, minimally invasive, and multiple organs affected during the surgery carries a role. Duration, if it is more than 4 hours, it is bound to cause a severe immune response. Pre-existing infection, pre-existing changes in leukocyte and or platelet numbers, pre-existing conditions like any comorbidities like atherosclerosis, obesity, diabetes, and all. Smoker, anti-inflammatory medication, what is if he is using any. Intensity of the tissue trauma, size of the wounding, multi-hits, multiple injury sites or type of injury, extent of the heat injury, that is pottery we are using, utilization of extracorporeal support like hemodialysis and ECMO, ischemia, reperfusion, injury or clamping, blood loss, transfusion, and as we discussed just before, invasive high volume ventilation will also lead to more inflammation, anesthetic regimen and perioperative medication, and other underlying diseases. So we'll discuss briefly any therapeutic interventions and protective strategies we can do and close this talk. So this is one technique said to be helping in our body to mount a response to prepare the cells for fighting the disordered immune response. So what we have to do, if you want to decrease the inflammation, either we have to see avoiding the heightened immune response, or otherwise prepare the cells to fight the immune response. So ischemic preconditioning is a sort of technique that helps the cells to prepare the mounted immune response. So there are three types: remote ischemic preconditioning. That means we do away from the site of damage or injury. We know, like in perioperative stages where we are going to operate, and local, nearer to the site of damage, and pharmacological. So coming to the remote and local, the technique applies a focused, time-limited ischemic insult to a patient limb. So this ischemic insult then triggers the release of humoral factors, modulate neutrophil recruitment, and primes the organism for a subsequent inflammatory challenge. So this ischemic priming may reduce inflammation-associated organ failure. So that's the technique they're going to follow in ischemic preconditioning. Coming to pharmacological, all these drugs are used. They're actually being studied in animals now, levosimendan and verapamil, ramilton, and all. So, which will reduce the organ damage. They act at various levels and they reduce the organ damage and inflammatory cell infiltration. So, nonetheless, the uncertainty regarding the precise underlying pathways and possible combinatory preventive approaches demands further research for their more practical uses. So coming to few pharmacological agents we can use to combat the inflammation. They're prone to dampen the inflammation, such as tocilizumab, a humanized IL-6 receptor antibody. Steroids or checkpoint inhibitors have been tested in different models of inflammation. So tocilizumab improved survival in both lung and acute kidney injury in a rat model of cecal ligation and puncture, and has modulated excess inflammation in a small cohort of COVID-19 patients. So meta-analysis studies assessing the usage of corticosteroids in septic shock patients suggests that hydrocortisone clearly facilitates reversal of septic shock, but does not clearly reduce the mortality. For immune checkpoint inhibitors, a meta-analysis of preclinical and animal data revealed a benefit in fungal sepsis model, but no clear effects in models without fungal challenge. So anti-inflammatory drugs which are easily available to us, or such as ibuprofen, have positively influenced fever, tachycardia, oxygen consumption, and lactic acidosis in septic patients, but not prevented shock, ARDS, or mortality. So in contrast to the anti-inflammatory like ibuprofen, aspirin pre-treatment reduced endothelial dysfunction effects in a human model of vaccination-induced inflammation, and may reduce overall mortality in sepsis patients also. So tranexamic acid may also exhibit anti-inflammatory effects via suppression of the mitochondrial DAMP release in cell culture and a mouse burn injury model. So this is a very recent study published in 2019. So coming to a couple of anesthetic strategies, the drugs here they talk about. Sevoflurane reduces neutrophil apoptosis in a mouse model. This is also published in 2019. And propofol suppresses neutrophil functions and NET, neutrophil effector transmitter, formation of isolated human neutrophils in vitro, which is again a 2019 study. So because to high tidal volume, ventilation may also trigger inflammatory responses. Adjusting ventilatory strategies in anesthetized patients may also affect perioperative inflammation. And also animal studies suggest that optimized positive and expiratory pressure, PEEP of 6 centimeters water, might reduce the ventilator-induced inflammatory response in obese rats in comparison to lower PEEP levels of 2 centimeters. So coming to endothelial glycocalyx protection, with regard to endothelial dysfunction, protecting the endothelial glycocalyx has the potential for modulating systemic inflammation. So in cell culture and animal models, overexpression of the inhibitor of heparin sulfate shedding enzyme heparinase 1 and heparinase 2 can inhibit the TL4 signaling and protect against LPS-mediated endothelial damage. So other modulators of endothelial glycocalyx also include Forsythia suspensa component filarin, which protects against the glycocalyx degradation. Okay, so this all looks Greek and Latin and more of in a research stage. When they become commercially available, we can talk about them. So the more practical point in the glycocalyx protection would be a clinically more relevant therapeutic intervention is the administration of starches. So these colloids have been shown to stabilize or even recover the glycocalyx after induction of inflammation in mice. I would love to hear from the people who are using colloids perioperatively more frequently, the effect of them on the perioperative outcome. So these findings are in line with data from cell culture systems and preliminary patient studies suggesting that plasma products might preserve glycocalyx integrity. So in contrast, crystalloids may damage the glycocalyx in animal studies in a fashion similar to epinephrine and norepinephrine. So surgical factors, these are the factors we know, but most of the times we can't control unless surgeon is a very good friend of ours and with reasonably good enough skills. So minimizing the tissue trauma, shortening the duration, utilization of support systems, and blood loss, and eventually the transfusion, both will trigger inflammatory response. So this is an important thing I found out, the effect of circadian rhythm. So this is another potential factor where there is a time of day dependency of immune cell functions. So the mice studies suggest an effect of circadian rhythm on leukocyte recruitment, endothelial adhesion molecule expression, and chemokine release. So this is the study they are talking about, published, and there are multiple other supporting studies too, published in Elsevier publication. So they concluded that the leukocyte adhesion and migration in murine bone marrow and skeletal muscle microvasculature fluctuated with the circadian peak values at night. We showed that these rhythms have physiological consequences. I'm just reading the underlined part, although entire paragraph is very important. So have physiological consequences through alteration of hematopoietic cell recruitment and overall survival in models of septic shock, sickle cell vasoacclusion, and bone marrow transplantation. So these data provide unique insights into the leukocyte adhesion cascade and the potential for time-based therapeutics for transplantation and inflammatory diseases. So though they studied more of in bone marrow transplantation, septic shock, and sickle cell occlusion, so they suggest this time-based therapeutic interventions for transplantation as well as inflammatory diseases too, which can include our perioperative inflammatory response. So the more coming to more invasive approaches, we all know the removal of cytokines, the cytokine response or cytokine storm, as we have seen in the during the COVID crisis. So in liver and kidney transplantation, renal replacement therapy actually reduced the levels of pro-inflammatory cytokines such as TNF and IL-6. However, the use of similar strategies during cardiopulmonary bypass did not affect the cytokine levels or the patient outcome in early trials. Maybe Anuradha madam can throw a better light on this one. So though they have seen helpful in liver and kidney transplants, similar results are not achieved in during the cardiopulmonary bypass. So to conclude, systemic inflammation is a potentially dangerous and poorly understood process, which you are very sad to say, but it's a poorly understood process involving the release of damage-associated molecular patterns, recruitment and activation of inflammatory cells, and breakdown of the endothelial barrier. Both tissue damage and infectious pathogens may trigger similar immune cascades, which is the major contributing factor for the dysregulated immune response. So future research is needed to determine adequate interference strategies, novel surgical procedures with reduced invasiveness and tissue trauma, which we are already going through the more and more refined surgery, minimally invasive surgeries, and also robotic surgeries with high precision and all. And innovative pharmacological regulators of immune cell activation and deactivation, which are in studies and phase 1B trials, and maybe in near future, we can achieve all those for the better patient care. So the precise time and space coordinated on-off switch of inflammation is the holy grail for perioperative inflammation research and holds tremendous potential to improve patient outcomes and reduce healthcare related costs. And this is what I felt I feel whenever I prepare for a class. So reading about the enormous amount of information regarding anything. So known is a drop and unknown is an ocean. So let's all read and share and make the drops to form an ocean. Thank you so much for the patient hearing. And here we conclude and discuss the more practical points to stop the perioperative inflammatory response. Thank you.
Thank you, Srikanth. Very good insight into that. Let us start with Anuradha. As a cardiac surgery cases, there is no inflammatory response you're telling now.
Good morning, sir. Good morning to all.
morning.
Srikant, very nice class. You maintained how to give lecture. Yes, last week Dr. Shekhar told, no? So you gave the only 30%. 70% I have to read because that topic is very tough topic. I didn't understand. So that's why last 2 days I tried to reading, but because of time, I can't tell because no time. So that's why I didn't read properly. So in cardiac, it's mainly three initiative factors. Number one is a contact activation and ischemia, reperfusion, and the third one is endotoxemia. So here number one is contact activation. That means when you're starting the CPB, the tubes, the blood is contact with the tubes. So here what happens is the liver and heart and lung and all organs are injury occur. So that is the number one. Number two is aortic cross clamping and removing of the cross clamp. So that 2 times also is injury occurs. So that is ischemia and reperfusion. And splanchnic perfusion also very low maintenance of BP. That time also damage occurs. And endotoxemia. So these are the main initiative factors. And going to the immune system activation, it is a complement system, cytokines, coagulation or fibrolysis, so endothelium and cellular immune system. So these are the things mainly it comes. So main these pathway, it injure the cell and everything. So it increase the neutrophils and cascade immune system is increasing. These are the things I read, but detailedly I didn't read. And you told about the anesthesia drugs. So anesthesia drugs is propofol is the best drug with the low concentration. With low concentration, it is not to injure the under post-inflammatory, it is reduced. I think thiopental also inhibits, and ketamine also suppress the IL-6 and IL-6 concentration during CPB. And morphine, I don't know. And fentanyl also increase the CD11B and HLA-DR. And midazolam and decrease the extracellular IL-8 accumulation. So these are things I read. And main is a beneficial effects in series is the immune system priming, prevention of infection, improved wound healing. But deleterious effects means cardiovascular, pulmonary, neurological, renal, hepatic, and immunological. So mainly, so here what happened? You told about the Willy. That means a higher tidal ones we cannot use. So as an anesthetist, when you are putting the ventilator anesthesia workstation, always low tidal volume try to maintain. So it reduces the delay. And in CPB, we are giving steroid, Solimedrol 1 gram. And in transplant, we are giving immunoglobulins and everything. So to reduce the defense system and everything. So these are the things I read. And how to prevent as an anesthesiologist, you have to tell.
No,
And
you
which
have told
drugs we have
maximum
to
points,
use?
Anuradha. You understand? You told maximum points. There is one question from Dr. Srikant. Can I please speak?
Yes, sir.
Srikant?
No, sir. Yeah.
Yeah, what Anuradha told is all the things explained, and what she is asking is practically how to improve. Dr. Surendranath has put a message saying that
No
this is the
block.
reason why you can put a blocks rather than the GA, so that can avoid acids.
Yes, sir. There is
Correct,
also
no?
like there is a similarity in the same mechanism has been this pathogenesis or process of DAMPs has been associated with even nociceptors too. So that's the a lot of research work going on there. So these nociceptors also work in line with the toll-like receptors, same similar mechanism of action like DAMPs and all. So that's what there are many studies which suggest that this perioperative injury and all. So how they cause the immune response on the similar line, there will actually cause the pain also will be associated with the immune response pathway. So decreasing the pain in any form like nerve blocks or epidural and all, so will definitely decrease the perioperative inflammatory response.
Surendranath, is that you want anything else, Surendra?
No, sir, no, sir. What I remember is definitely neural blocks decrease the local SIRS response. Systemic response, anyway, you have to optimize the pressures, optimize the organ injury, what I remember. And one thing is Dexmed, that is a central sympathetic activation. If you maintain the Dexmed, there is a good, in anesthesia, what I remember is it has a good decrease the systemic inflammatory response. These things only I remember, sir.
So,
But the points I want to discuss are the more practical things we are using. Like, uh, how many of you are familiar using colloids regularly in major surgeries like that?
is a controversial topic, no, Srikant, the colloids
Yes,
using?
sir. That's what like in the
Because,
study and all they have given very positively for sirs. So I'm asking any of us are using regularly colloids and all for the major
I think,
surgeries especially.
I don't know, for that purpose, I don't think nobody is using. But only thing is, because that has its own complications of coagulation effects, no?
Yes.
So definitely
Maybe
colloids. I think so. Colloids. I think now hydroxyethyl starch is. I think I don't know in anesthesia. Actually, no, I'm not practicing active anesthesia. I think we are not using hydroxyethyl starch. Rest of the things, albumin and 5% albumin. I think it's not available, but I think you can go with 5% albumin. Hydroxyetherostat has its own problem when you are using for major surgery. But if you want to restore the volume for a brief period of time, you can go with it because it has an acute kidney injury, it has a problem with coagulation. So many trials has done. Definitely, hydroxyetherostat has its own downtrending, but 5% albumin still it has a role. I think its availability is the issue. Rest of the things I don't. I think rest of the colloids I don't think so it has any. I didn't read any recent trials also.
so this point is valid, Srikant. As a critical care side, what we know is only the 4% or 5% albumin is useful. But in anesthesia, maybe you are the better person.
Yes. They approve alles. I didn't use so much colloid because of the same reasons mentioned by Surendra. But now I don't know, like if they're using for major surgeries and all. Want to
That is
speak about
dynamic analysis then.
Chaitanya sir.
Mm.
The colloids and the steroids, both I want to ask how much they're using for major surgeries and all.
You know, major surgeries, oncology they're doing. No, what is it? Your answer, Chaitanya? Sir.
Maybe she's busy.
She's not there.
Sir, for
Huh?
cis response, I didn't remember the evidence, sir. But we used to give, whenever there is a major response, we used to give dexamethasone 8 mg when I'm practicing onco anesthesia. Used to give 8 mg dexamethasone to prevent two things. One is to prevent the SIDS response immediately, and one is the PONV. To prevent these two things, we used to give 4 mg for the minor surgeries, 8 mg for the major surgery, one dose pre-operatively. These things we have followed for quite period of time. For a small, not for small surgery where there is a prolonged, there is a surgeries of more than 5 hours, 4 hours surgeries. What we practiced, what we come across, not having much of infectious risk, but definitely there is speeder recovery from the and from the ICU and ORs.
Okay.
What
So,
I remember.
only single dose before surgery?
Yeah. Yes, sir. Was to give single dose.
Okay.
Are you practicing the same thing, Chaitanya? She's busy, huh?
Hmm.
Anyway,
So-
Rani madam and Manjula madam all are there, no? Raman Prasad sir is there.
Because even though in critical care, but because in case of major surgeries, they will be immediately thrown to ICU only. Even as critical care patient, we manage the major surgeries.
That is the reason I thought that everybody should be attending this, because most of the post-op cases will come to the ICU. And nowadays in many hospitals, anesthesiologists are working only in the intraoperatively, and post-op, most of the people are handing over to the critical care people. In some major centers, including maybe if it comes to care also, I think critical care is seeing more, no, post-op. Dr. Rani madam?
Sir, first day we are seeing, next day we are hand over to critical care because we know the patient is some more days we need ICU. So that's why immediately we are hand over to critical care.
Yeah, that's the reason I'm asking Rani madam and others also. Manjula, what is it? Your I mean, valuable inputs.
Sir, I don't know about that dexamethasone preoperatively because I have not done many onco cases, but it is used mainly for the PON, like who are not responding to other drug anti-vomiting drugs.
See, dexamethasone is used for antiemetic or whatever it is, but it's going to, if you see the cardiac surgery, Anuradha is telling they're giving steroid for the pump. And if you see the oncology, and Surendra is telling that they're giving 8 mg major. And if you take the transplant cases, we are giving. And any major surgeries. So in that case, if you see steroid versus colloid, can we have, is there any comparison only steroid versus colloid, Dr. Srikanth?
But colloids nowadays they are not used only, sir. They are not recommending anywhere to use colloids.
Maybe as Surendra has pointed out, we can use as 5% almond if it is available instead of hydroxyethyl starches. And also, one more common issue we face, I want to bring it to light, is the sinus tachycardia. Post major surgeries and all, especially, unless for minor surgeries we don't see. Post major surgery, on the day one, which is the most turbulent phase of the perioperative period. So we are seeing in some cases that persistent 140 to 160, despite giving fluid, adequate IVC and all. Any measures to counter that, or any experience in dealing with those type of cases?
Can you repeat the question, Srikanth? Sorry, I missed it.
Sir, especially after major surgeries, sir, I mean like some major abdominal or any other polytrauma like that. So we are in 30 to 40% cases, we are seeing a severe sinus tachycardia. No rhythm disturbance, only sinus tachycardia, like 140 to 160, sometimes shooting up to 170, 180 also. But with fluid bolus also, there will be a transient response, and again, it gets shoot up. IVC is adequate. Even then, we are seeing that persistent sinus tachycardia. sometimes it's getting settled down on this day two, but can we do anything additionally to counter the extreme tachycardia? Any experience of dealing with those cases?
I don't know. It's only my theory thought process, Shrikant.
Sir.
Because we are not having exactly fluid intravascular status to monitor. Second thing is we don't have a BIS monitoring of his pain and depth of anesthesia. Third one is a pain assessment score and coming out the relaxation, how much depth is there. So those things, because normally we are more worried about eras. Nowadays, everybody is talking about eras. When you are coming about eras, your goal is to get him out of the situation fast. So that is going to be a very, as you said, very tachycardia. The tachypnea is not there because of anesthesia and ventilator. Tachycardia is there, that's the only response you have. As long as the response is there more, then automatically you'll have a tachycardia. So that the depth analysis of the post-op ICU, I don't think any one of us regularly, because of the cost or technology involvement, we are doing it. Because once what I've noticed, maybe long back or whatever it is, any tachycardia comes, first thing is we look at all these 4-5 things. One is the volume status, second is inotropes, and second is heart contractility, and the fourth is pain condition. So all these things, irritability. So I think that assessment will solve maximum problems. And then you can think about SIDS. As I said, humoral immunity and cell-mediated immunity, how do you really monitor them in the bedside or in the ICU, Srikanth? Because it's not easy. Immunity we know and immunoresponse we know. How you are going to see that?
So scoring system they have mentioned in this it's also with CRP and Q SOFA scores to assess the information. CRP is easy available thing. We can
CRP is the one looking at the response, inflammatory response. What it is. Yeah.
I think for any major surgery, it's better to do CRP on day one and see how.
You want to do CRP pre-op or post-op or both times? Then only we know the difference, no?
Baseline CRP, if we know, it's better for at least for major surgeries. I think we can go ahead with the pre-op CRP.
Because that was a single line in the era of COVID. That was a one parameter to discharge the patient. The CRP is less than 6. Don't think anything, just discharge.
Yeah, but sir, after major surgery, after any inflammation, CRP will be very high anyway. So, if you are looking at CIRS response, maybe it's high, so you think of that, but we shouldn't get confused whether it's infection, post-op infection. First 2 days, temperature and high CRP, it's because of CIRS, because of inflammation only, can't be because of infection, unless preoperatively only they are brewing up something, organisms, it flares up, that's a different thing. But pre-op, fit and well person, CRP definitely will be high. So doing that, I don't know whether it's justified, but as Srikanth said, try to reduce the immune response by maintaining perfusion, proper pain relief, reduce post-op nausea, vomiting. We used to give dexamethasone for all major surgeries, mainly for purpose of PONV, but that also acts as anti-inflammatory. So to some extent, probably it would reduce the CIRS response. And as Srikanth said, we never give dextrons like starches. We used to give 4% albumin, 4% or 5% albumin. But sometimes, very occasionally, before you get blood, if there's a sudden massive blood loss, like we used to give up to a liter of chelofuscin, but not more than that, before you get blood and blood products. This is what we used to do. And pain relief, pre-op anxiolysis, all these are, I think, major factors also contribute to immune response? Answers.
See, as the definition itself, the sepsis is dysregulated response of any individual. So even its SIDS also is dysregulated response of the each individual, no, Srikanth?
Yes, sir.
So that is where the question comes that how the people are going to get respond. It depends on the person. So CRP is not a marker of infection. It's a marker of inflammation, right?
Yes, sir.
You cannot conclude this as an infection.
But again, infection also stimulates this immune response and all inflammation. So that is the basic problem they have been highlighting all through the discussion. There are a lot of similarities between the infectious and non-infectious process causing the inflammatory response. So it's very at this point of time. The diagnostic tools or the so-called what all we have the clinical findings also, it's very difficult to differentiate between a perioperative infection causing the damage and perioperative inflammation causing the damage. So what this is.
ఇంకేమైనా ఉన్నాయా రాణి మేడం మీకు తెలిసి?
Sir,
యా చెప్పండి ప్లీజ్ మంజులను.
sir, actually we used to say, na, sir, during COVID time, CRP is only that inflammatory response, and that's why we used to see that PCT also along with that, just to see that there is any infection, a superadded infection or something like that. That is how the follow-up was happening. CRP is only like inflammatory response.
No, I understand. Rani madam is telling that they're not giving colloids and we cannot see the response of individual because even surgery can increase the CRP. As said, inflammatory
Yes, sir.
response to CRP. So, do you have any other markers, Rani madam? She's not responding. Okay,
Sir,
madam. Check.
I don't know whether we can do ferritin and all these at this level, but they are also the markers. Platelets in inflammation, like they aggregate, and in the film we may see less platelets.
But what I mean presently, like CK-MB is the first 3 hours, then after 6 hours to open in the same way. This is there inflammatory markers, Dr. Srikanth. The early is going to rise by CRP, the later is going to fall by the platelets or ferritin, like that. Is there anything, Dr. Srikanth?
No, I just have to go through.
Because that is what gives, no, like for example, if you say the CRP is going to rise in the first 6 hours, then afterwards it's going to fall or something like that, because if the response is going back. I mean, as you said, it's inflammatory response. So just like that, I'm asking. Anyway, this is what I thought from my side. I don't know, but it's
Hello?
a very good class. The only doubt is about Chapani.
Sir, what about SDD? Any useful?
What is it? What is it, Anuradha?
Selective digestive decontamination.
That is
And,
for
enter-
only ICU. See, that selective decontamination in the OT already fully cleaned up. It's a clean case. SDD
Okay.
is not at all useful and nowadays in ICUs because only in the Netherlands where there's no, where they have used that medicine chlorhexidine, and that was prevention of VAP they did. But SDD for this inflammatory response, there's no connection at all as far as my knowledge is concerned. I don't know. Somebody else can throw the light.
What about enteral nutrition and immunonutrition? Any useful for this patient?
Yeah, definitely. See, for any case of malignancy cases or cachexia cases for who are preparing for the surgeries, major surgeries, they keep the patients pre-op admission for 3 weeks. Then they feed the patients and analyze the nutritional status. then there is another thing which actually improves and increases, but there's no immunonutrition, there's no much goal, no role. So, but normally nutrition has definitely a big role in the patients where they require, because as long as it's a borderline, that's the reason we can put in ICU that don't have to worry about first 48 hours or hemodynamically unstable patients. And you can go up to 60 to 80% maximum requirement. And within a week, we should not go for a parental shift, otherwise not required. So nutrition has a bigger role. But the thing is, for this, it's post-op. No, I don't know. Only Srikanth has to throw light.
The better to, if possible, try to as early as possible. We have to start enteral nutrition. That is the first one. And if total count is rising, we can think about the SIDS. If CRP is rising, that also we have to thinking it is rising. If decreasing trend means SIDS is reducing.
Srikanth, how much time you are doing NBM?
NBM, sir.
Normally NBM, your duration is reduced, no?
0, sir.
Yeah, NBM is 0. And even the post-op early feeding also you're starting, no?
Early feeding.
Early feeding. So that covered everything.
Unless there is a surgical contraindication, clear-cut surgical, not surgeon contraindication. Unless there is a surgical contraindication, we are feeding early, sir.
Yeah, right. That answers Anuradha's question. Yeah.
Okay, sir. It's 9 o'clock. When?
Srikanth, you asked about tachycardia post-op, right?
Yes, madam.
Post-op tachycardia, like as you said, after ruling out pain, agitation, and tubes and all these things, discomfort, and ruled out all those things, and urine output good, IVC is full, still tachycardia, then like rule out any cardiac conditions and see if you have any DOBU or dopamine, all these things ruled out. Still tachycardia, sometimes like if it is more than 140, 150, it may compromise your blood pressure. So at that time, like we try to give small dose of either beta blocker or evabrad. We are doing that in ICU. So just to get it to around 120s like that, not 150, 160. Yeah. And do ECG and make sure there's no cardiac issue and rule out all these and then try to give. Okay.
Oh, thank you.
Chaitanya busy unda?
She's not there now. Maybe case starting lo palakarinchindi tarvata I think she got busy there. No. Okay, sir.
Thank you, Srikanth. Bye.
Thank you, madam. Thank you, sir. Thank you, Anuradha madam, Mohan sir, Rani madam.
Thank you, Srikanth. Thank you to all.